providing quality care close to home. The time is, I guess, about 9 o'clock. So, call to order. Do we have a quorum? Yes, we have a quorum. Have we posted everything correctly? Heather, everything been posted? Okay. Next item, public comment. Do we have any public comment? Next item is approval of the minutes from the last meeting. Do I have a motion to approve the minutes? Do I hear a second?
Second.
Any discussion? If so, all in favor? All opposed? Unanimous. The next item is quality medical staff report. Dr. Conrad, he's busy this morning, isn't he? Okay, I don't guess he, maybe Courtney if he had anything. Clinical service report, Courtney Alford.
Good morning. Dr. Conrad didn't have anything to report, but we did want to say flus are going down. Haven't seen any measles. Everything else going pretty well in the emergency room. As far as nursing or clinical services, I just wanted to say that I did hire one full-time night shift RN last night and another night shift RN that potentially wants full-time hours when she moves out of her current job. So that's a huge blessing. Two more nurses and night shift nurses. So.
Courtney, how many nursing positions are we down now?
I don't know with those two. As far as we're down a couple, 2 or 3, but night shift's always hard to fill. And I've got one PRN night shift nurse that I'm going to be moving to full-time night shift as well. So night shift's looking a lot better than it has in years. Much better.
Would you say you have sufficient nursing right now?
Yes, I still have a lot of PRN.
Always on the brink. Okay.
Yeah, and I have a lot of PRN still for day shift, but they're strong nurses. They work well, so it's okay.
Okay.
So, then I wanted to update you guys on the sexual assault program that we've been working on. We did sign that contract, which was active the first of the month with the Gulf Coast Children's Advocacy in Panama City. And so they are serving us for our sexual assault needs. But Mr. Walker and I did meet with Emily, who's the director of the Refuge House in Tallahassee. So we're working on trying to get them to come in because they're actually responsible for Franklin County. So we're trying to get them to come in and make it a little bit easier and smooth for them to come in. I do have a meeting tomorrow. They're looking for a location, a private location, to bring these individuals in so that they don't have to come to the hospital and be charged for an emergency room visit if that's not necessary, if they just need the exam. So I have a meeting with a provider tomorrow to look at a potential site for that, and then I'll update Emily after that. And we've been working and updating the Sheriff's Department with that also.
My report. One, two. Pertaining to clinic, not clinic, Courtney department, AUR, surveillance subscription software. That's something that we're working on. It's a CDC mandated software now that every hospital has to start reporting what they call antimicrobial use and resistance. It's really the reporting on antibiotic stewardship. Hospitals are using antibiotics appropriately. Our electronic health records, TrueBridge vendor, they offer a subscription for us, but we think that the expense is just too much money for $17,000.
How much?
$17,940.
And that's a requirement by ACA?
Yeah,
CDC.
Yeah, CDC and CMS. Now we have a $13,000 grant, that we'll put towards the subscription fee, but we've also talked to 2 other vendors. Their annual fee is like $9,000 a year, $10,000 a year, but they have like 5-year terms. So we'll still be doing some research in that area, so we can get that mandated software. Now, we normally report to what they call the National Health Safety Care Network. We do reporting in there anyway, but with this particular report, the federal government is saying, hey, you have to partner with somebody that we have certified, quote unquote. And the report is not that detailed, but it's maybe cumbersome to pull from our system. So that's something that we're looking into to get that so we can be compliant, ready for that end.
That's right. So the NHSN is a system that I have to report all kinds of flu, RSV, and COVID in daily or 5 days a week, and then on Monday I'll update the Saturday, Sunday. So we're already in that system, but they are mandating that we use a vendor for this service. So
So David, does that require a vote from the board?
No, that was just updating the.
Just
board,
updating it.
You know, what we're doing in that area. And then also, Alliance, David Bowling, he'll talk with the other line hospitals that use TrueBridge, you know, just to see what they're paying for that particular software, that fee, you know, to see if we're close to it. You know, if we're close to it, you know, it'd be easier for us to go with our own vendor. We're already in our electronic healthcare system. But I just, you know, $17,000, and somebody else charging me $10,000. Like, hey, what's the problem? You know, so that's why I've been taking that thing. But it's a mandated.
I have a question. If I'm not mistaken, I asked this question several meetings ago. Don't we execute favored nation pricing with all our vendors? I mean, if you were to find that you were paying $17,000 and somebody else is paying $10,000, that's a violation of the favored nation pricing. And favored nation pricing, if I'm not mistaken, is sort of a mandatory situation for all Florida government agencies or agencies. So, again, I will go back to the question, do we have favored nation pricing responsibilities? Do we have to notify these people?
That's something, you know, they want to speak on that part.
I don't know what you're talking about. What are you talking about? What is favored nation?
Favored nation means that basically you are guaranteed the equal to or lower price in any other vendor or that vendor sells to any other unit within the nation. In other words, we should be paying the lowest amount or equal to the lowest amount for a product. And that's why I'm asking the question.
Well, do we, is it a statute? Is it a Florida statute?
It could be. I don't know. But I know that all the state contracts that we ever executed, we had to have favored nation clause in.
That's the state of Florida. But we're not.
Department of Transportation, you want me to keep going?
I think my question was a valid question.
I didn't say it wasn't, okay? Let's don't go that route.
I think it's worth exploring though, if it's something, could y'all look into that and see? Oh.
John, we'll check into it. I mean, I'm not real familiar with favored nation, but we do participate in a group purchasing organization, GPO, and that's provided through the relationship with Alliance. So, and that has buying power across the United States. So it is
basically
a group,
different types of
it's
products.
A group purchasing organization. Well, I mean, there's supplies in that, there's pharmaceuticals in that, there's vendor relationships in that as well. But I think this particular application, what David was referencing earlier, he got a quote from the vendor. We have other Alliant-based facilities that utilize the same vendor, so we're able to see comparative pricing to try to ratchet the price down, and should be able to again with the relationship. But we'll check into the favored nation opportunity and see if there's something we can do there.
Yeah,
Thank you.
And most hospitals have what they call GPOs, group purchasing organizations, so that they can get better pricing for their vendors. Years ago, we were under a program called Vizient, and you know they were charging us more money. And when we came apart with Alliant Purchasing, you know we're getting 25, 50, 30% discount. You know, but most of your hospitals have GPOs. You know, and those GPOs have great buying power. And with Alliant Purchasing, they have buying power over the whole United States, really the whole nation, really. So that's why we're able to get certain pricing on that. I just wanted to let the board know about that.
Okay, last thing I have is, I was just going to do an update on swing bed. I just wanted to let you guys know that our swing bed coordinator, Dan, is making weekly trips. Once a week, he's going to Bay County and visiting the facilities there. Then that following week, he'll be in Leon County. Last Friday, he was at TMH and CRMC meeting with case management. This Friday, he's going to be at Gulf Coast and Bay Medical in Bay County. So trying to increase that communication, take them some goodies, be a little more present in their facilities. Also, we're working on an activity room for the swing bed, so we're transitioning room 108 to be an activity room. So we have, we'll take the patients out of the room. They'll get out of the room to get physical therapy, go outside, different things. But this will offer activities as far as games or art, different things like that. So working on that with Craig and Dan. So we should have that completed by the end of the month. So that'll be nice as well. And then we are working with EMS. James is getting us reports on all the transfers that don't come to our facility that would be potential swing bed candidates. So he's sending us that information so that we can be in contact with the receiving facility. And then Dan is reviewing the transfer log in the emergency room as well, so that any patient that wasn't admitted but transferred straight from the ER, we can follow up on them as well. And we're doing that with a relationship with Lori Franklin with Alliant, because she has a little more insight to those facilities than we do. So we keep her in touch with all those patients as well that never are admitted but maybe are seen for our EMS or our emergency room, and she's helping us to follow up on those patients. And Dan visits them. He visited 2 of the 3 that EMS transferred out last week while he was there Friday, the actual patients. Little patient contact and case management as well for our local residents that are being transferred out. So just an update. So we're trying to touch a little bit more patients and touch different areas for potential swing bed patients.
Courtney, the last meeting, I was trying to remember the name of the place in Tallahassee, that's where my mother went, named Compass.
Encompass.
Is it Encompass
Yes,
or
sir.
something? I went by there the other day and I wrote it down in my other truck somewhere.
Yes.
So it's a real,
Big rehab
are
facility.
y'all looking at that, y'all?
Would be like one of our,
Competition.
kind of like our competition in a sense, except that Encompass is inpatient care. So when they leave a CRMC or TMH and they can go to Encompass, they're actually considered inpatient like they would be in one of the larger facilities, whereas, so they could use that Encompass as like a stepping stone and then come to us.
Okay,
From
yeah, that's
there,
what I
if
understand,
needed,
that's the way
yes.
that happened, yeah, okay.
Yes, so the
All right,
same.
well,
Yep.
it was just something I didn't know. if
Yeah,
we-
no, they're a big facility in Tallahassee,
Okay,
Bay
all right.
County. So.
In Bay County as well.
Mhm.
All right, Courtney, quick question. With the nursing shortage that we have, a couple nurses were short, we're not running any large OTs, are we?
We're not. We're cutting down on that now. We do have some overtime nurses, some nurses that work 4 shifts a week sometimes to cover. But like today, we only have 1 patient, so I've cut a nurse. So, trying to make that adjustment where I can. But these 2 new hires are going to help with that for sure. But until, you got to have the shifts covered if you got the patient. So it's a balancing act there.
Because apparently somebody's watching that OT, so.
Yeah, I'm sure. We also have to take care of the patients and keep the nurses happy.
How we
Again, it's a
doing
balancing
how we
act.
doing training programs? Still?
Oh, good. Yeah,
still-
good. We're
still got
set
some
up
training
with
for
Vicki
nurses?
again for another BLS, ACLS, and PALS class in May. And then the trauma nurse in the TNCC is almost due to be recertified, the nurses to be recertified. So I've reached out to her actually this morning to see about getting that in. I don't know a cost or timing for that yet, but.
Great, thank you.
Sure.
Anybody got anything else? Okay, thank you. Next item is Miss Susie Bruce, I can't never pronounce your last name. Susie, how about that? My wife's name's Susie. My wife's name's Susie, yes, I know.
Good morning. It's been a little while since I've been here, but I've been up in the Caravel location training with my new staff member up there. So her success will be my success and the clinic's success if we get somebody in and they train up really well and do a good job. So that's why I spend so much time there. We are experiencing some really positive growth in the clinics. Of course, we have Dr. Catlin and Doris Carmichael change their offices, so they're in East Point, but we're still getting some of their patients over to us because of the dynamics of their contracts with insurance companies. And a lot of the larger facilities are dropping insurance companies as well.
Really?
Yeah, so TMH and Ascension dropped WellCare and some of the other Medicaid plans, and they're coming over to us. So with that new growth, we have, of course, a few challenges that we're going to meet with, different things. So once we have our new phone system in place and we have it publicized, we'll be able to list some of the things we want to change. And one of the things I want to do with that is we're going to direct patients to make sure that they call the pharmacy first. Instead of coming into the office or making phone calls, I need this, because it's about patient education and making patients a little bit more responsible that takes the burden off the staff. People walking in and stopping, and so, you know, every other facility does this as well. Every other doctor office directs the patients to have the pharmacies call us. So it's
Yeah,
very
they all
trying.
do that. Everybody does that.
So we're going to make sure that we enforce that a little bit stronger. I'd like to implement the no-show fee moving forward, because that's part of our challenge with being able to take walk-ins. And again, we're the only medical facility in the area that takes walk-ins. So if I have 4 or 5 people a day no-showing, that hurts us with the timing of those appointments and how they're done. It's a challenge, right? So I'd like to implement a $25 no-show fee that's paid before the patient's seen again. One of the things with that, though, is you cannot charge a Medicaid patient a $25 fee. And that tends to be one of the population that does the no-shows. So we'll be watching it a little bit more clearly about how many times a person's no-showing before they're discharged. Because they are taking up a lot of the time that could be well spent on someone else that needs that care.
Susie, are we in line with every doctor I've ever been to? There is a no-show fee. What time, 24 hours or 8 hours or?
I think it's fair to say, 4 to 8 hours, yeah.
How much?
It's 4 to 8. Most people say within 24 to 48 hours they have time. We're not at that growth part, right?
Let's make sure we're in line with everybody else, yeah.
Well, 25 is fair because of our population in the area. I just went to a doctor's office, and her charge was $110.
$110?
$110 in 24 hours. But it makes an impact, right? People are like, whoa, I'm going to make sure I call them to let them know
Yeah.
I'm going to change my mind. So not at that gross of a growth, but we are getting there. And I'd like to make sure that we're utilizing our time with our providers well spent, because we do have so many walk-ins, and especially time during tourist time, which is not picking up here. We need to have that flexibility in our schedules. We still have the same 2 great providers. Amanda Page has signed on. She was only scheduled for 2 days a week through June. Now she and I discussed she's going to go through the end of the year with us too. So 1 day at West and 1 day at East to help with the coverage until we get a provider. Another physician or another nurse practitioner. We're still actively looking. We were in discussions with a physician who chose he would like to do his sports medicine instead of what we were offering. So, but he wished us well, and he was really interested at some point. But this is a unique area to become a physician and practice that. So we're going to do that with the no-show fees and the prescriptions. And one of the more positive things we want to do, I'd like to offer patients to come to the clinics and be signed up for Medicaid. So that I'll be doing that, working with Heather with that, and also with the Gulf Coast Collections Agency. We'd like to make sure that we're getting correct addresses and more of an interface with them so that we're moving forward with people's balances. Because at this point, we still see patients with Gulf Coast balances, right? Because we're one of the few facilities in the area, but we have to make sure that that's being collected in some manner and it's coming back to us. So we'll be doing that as well. One of the things that's coming up is it's springtime, and so the 2 providers, Suzette and Dana, will be taking some continuing education courses early in the year instead of at the end of the year, so they have some family time. But they're going to be doing it in March and then April. So at that time, the clinics are going to be bringing in Amanda to cover some of those days, but there won't be every day that we have that. So just to let you know, some days there's not coverage with the provider, but the other clinic will be open and available. There's only 1 or 2 days throughout the year that I won't have somebody at those places, and that's because they have personal vacation time. But it's well thought out, so there's a good balance. And one of the other things that along those lines, because of our growth, so what people don't understand is insurance companies now are denying more and more things. They're denying more medications. They're denying more diagnostic studies. But when that happens, it creates more work for us in the background, because we have to follow through with the prior authorization, or the provider has to come up with another drug that's just as effective as the drug that was denied. Then you have to send that paperwork out to the insurance company. It comes back to my staff. They have to reprocess. It's a game back and forth. So each patient is quite a bit of work. And especially in our area with no specialists, we have a lot of referrals and a lot of prior authorizations for the type of insurance contracts that we have in our area. So that all takes time. So what we're doing, we're trying out. We've already been doing it with Suzette. We've been doing it every other Friday as half a day, so the provider has their personal time to do things, and then the staff has time to catch up with all of that collaborative work. So we stay on top of the authorizations. And so what we're doing with both Suzette and Dana, we're going to have a half a day every other week on a Friday, because that's typically our slow day in this community on a Friday afternoon, even with the tourists, because nobody comes to look after them. If it's raining, if it's snowing, or if there's on Friday afternoon, that's your slowest time in the clinic setting. So, but the staff will be there, we'll be working, it's just an opportunity for us to catch up with all these processes. And other than that, anyone have any concerns with the notion?
Go ahead, Bill.
I was in the clinic the other day, and I was just wondering, this is a rather minor thing, but is there any way we could cut back on the amount of signatures that are required on the intake form?
Yes,
Holy
we're getting
Christ.
our-
That thing,
getting our
I
iPads.
signed my name more there than I did on my mortgage.
Thanks to whoever was here in 2016, yes, they created 7 forms. And so we're getting these iPads instituted at the front desk.
Oh, that's
that
good.
you can just integrate into the system. We're going to be doing a lot more of that. We're going to be encouraging our patients to sign up to the portal for those that don't have security issues or are concerned about breaches. But it's all very HIPAA compliant. Our systems are checked all the time by both our IT and my FINA. But yes, they'll be doing iPads to sign in. Do a little bit better. Yes, it is daunting. Trust me.
I mean, that last page is a bear. I think you have to sign your name 10 times or something.
Yeah, I didn't make it up. I didn't make it up.
Susie, let me make this clear. It's $25 for no-show. How many hours in advance? 48?
I would say at least 4 hours in advance.
4 hours. Well, it
I
needs
mean,
to be a
It's
policy.
to our discretion too, that if somebody goes, hey, look, I broke down with my car. I
Oh,
can't
I understand
do
that,
it."
yeah. 4 hours. That's reasonable right there. Normally it's 24 or 48, yeah.
Yeah,
4 hours,
I mean,
okay.
I'd be happy to extend it, but
How
I
would,
know our community.
does this require a policy change?
It'll be a policy that'll be written up and posted. It'll be
Okay,
posted
good.
on our
Let's
website.
don't do it till we get the policy changed.
Right. That's why I'm bringing it to you also, you know, because I
Oh,
know how
yeah.
the phone calls go. Nobody calls me, they call the commissioner with you guys.
I know, they don't call me, but I mean, that's what I wanna know. And, 4 hours, I'm fine with that. Has the board got any comments on that? We'll be reviewing the policy.
How do you cover people who have appointments on Monday morning?
How do I cover them?
Yes, in other words, they got to cancel because
Right.
something happened over the weekend.
Right, we arrive at the office at 7:30 in the morning.
Yeah.
So
We're there,
if
so
they,
we're picking up all of our messages at
okay,
7:30.
so if they call in and it's on that
Right.
message machine, then,
It's on the machine, hopefully, right? And the
Okay.
new wonderful phone system, and or if they go to the portal and sign up on the portal and let us know that way, we check your vote.
now, did I understand your explanation earlier that it pertains basically to the coding on cases, as far as having to review it, go back and rewrite it? Am I assuming that, or
Coding for what?
coding
Insurance.
on your records?
I think he's talking about the insurance
Oh,
payments.
no-show fee?
Yeah, yeah.
Mhm.
No, that's a statute that you cannot change, you cannot charge Medicaid patients in all states. Right? In all
No, no.
states?
That's,
You're talking
Yeah, no,
about-
but he was talking about, I think, the insurance, like, somebody come in, they come in, I'm a patient, I come to the clinic, and my insurance is not taking, well care, for example.
Right.
Maybe, whatever. And then you're saying that you have to go back and do other research.
Right,
like-
well, we do. It is not just coding, but there are many facilities in this area that are dropping smaller insurances and those type of insurances. They don't participate with it. There's many, many facilities in this area don't participate with these local contracts. So and because we don't have the facilities closest to us, we're trying to find somebody in Tallahassee for major facilities who will take this type of insurance. A lot of insurances are dropping their coverages of diagnostics and most of the drugs.
Okay, so we're not, if the patient is not assigned to us, except I'm assigned to another facility out here, the physician office, and they drop them.
Who does the assignment?
The managed care company, the insurance company.
Okay,
Insurance company.
okay, go ahead.
Yeah, so
They
insurance-
usually assign it to somebody within 25 miles of
Yeah,
your house.
yeah.
Unless when you're talking to them, when you sign up for an insurance company, if you tell them my preference is to go to Suzette Valdueza, then if they're in network with them, then they'll assign it to us. Or if they don't give a provider's name, it has to be their Dr. Conrad's name because he is our supervising physician.
So, for example, if I went to Dr. Kelly, and Dr. Kelly said, okay, I'm not taking no more of your insurance. Then if I go to the clinic really can't really, you either got to help me call the insurance company so that I can be assigned to them, but if it's not,
Well, it's on the patient.
Yeah,
The
it's on the patient,
yeah.
right.
So we do a lot of education at the front desk before they even get in the door. As we're making the appointments, as they come in and talk to me, I do a lot of, that's part of why I want to do the signing patients up for Medicaid. Because I do a lot of this all day long, talking to patients about their plans and trying to encourage them what's best for you as far as your prescription plan and what your privileges are, what's going to work best for you in our area, right? So if it's an HMO and they have someone else on their card, they definitely have to go to that doctor that they signed up for. So the more that we can educate the patients at the front desk before they even go in the back, it's their choice of what they do. But if somebody's there and they really need to be seen, we hold their appointment for them and have them talk while they're in the lobby to the insurance company. Most of them will change it over right there at the spot. It's their choice. We're not telling them you have to. We're just saying, hey, look, if you really want to see us,
Yeah.
you have to change your HMO to our name. And then they'll do it online, get a reference number, and do it.
Yeah, let me get,
How does that tie into your opening comment that the insurance companies are cutting back or see?
I'm talking about with our growth, there's a lot more work that goes with it. So I have the same 4 staff members that are doing all the tasks in the background, right? So that's why I have to make some adjustments in what we do in the day. We got to still have those same 4 nurses or CNAs or LPNs doing the rooming of a patient. They're doing prescription refills. They're doing running specimens and they're drawing the blood work. And then when they get on, we do the clerical portion where they're doing the tasks of authorizations and referrals. So that's just creating more work, and especially now because the insurance companies are changing of what they're going to
yeah,
cover.
let me just give you a quick example. My wife had an appointment in Tallahassee last Saturday. We get there, she gave me the insurance card, and said, oh, no, we're not taking Florida Blue.
What?
Like y'all didn't tell us.
They're not taking Florida Blue?
Yeah, this company, this physician office. So we like, well, we drove 2.5 hours. You know, so these are some of the things that happen in the clinic as well. You know, people come to the clinic unless they call us, we kind of educate them before they get there. But my wife called the phone. They said, yeah, nothing has changed. They still have the same insurance. I said, okay, we'll see you Saturday. So we drove up there for it. Again, we had to change the but a lot of insurance companies are dropping. ACA, they're suing United Healthcare. There's a big lawsuit. You know,
Yeah.
$147 million for that. They're suing them. And I got on my report later. I talk about, Sunshine Health complaint. That I filed with ACA. Because we're not getting paid properly. So the insurance companies are doing a whole lot of tricks, but a lot of facilities are really dropping insurance companies. So check your coverage to make sure your providers are taking their insurance companies before you go make that appointment.
I got a friend in Dothan's a general practitioner, and he don't take insurance anymore. You give him $2,500, $3,000, I don't know.
Yeah, a lot of
Then
doctors.
he's your doctor. And Rodney told me he don't have to have any clerical staff much. He don't have to fool with insurance. He just treats them, and you got his own cell number, and he takes X amount of patients, but they can call him at home at 3:00 in the morning and stuff.
Sure, he's not a vet.
But I'm just saying, that's. I think a lot of them are going to that.
Yeah, a lot of doctors are going to that model, especially up in Maryland.
What is it
DC
called?
area.
I don't know. It's got a name to it, but
I think it's something like Olive Heart.
I guess.
Something
But
like
he
that, yeah.
knows some people that like it too.
Yeah. But part of
Susie?
being rural health is we have to be here for our community.
Yeah.
They need us,
So
right?
the,
Susie, who's the worst offenders on the insurance list?
Well, I'm going to get in trouble. You know, this is televised, right?
so what did you say, earlier, when you, about Dr.
Bill wants to
Catlin?
go to work for him again. He's an insurance man.
Will you repeat what you said about Dr. Catlin earlier, when you first?
Well, they've moved from up in our area, so
Carabel to
then
East Point.
from Carabel, he's down to East Point. So
Oh, okay.
everybody's coming to us in Carabel.
Oh, okay.
And with the growth in Crawfordville, some of them are going to come down.
They're
to
coming
us,
in.
right?
Okay.
So, I mean, we welcome it,
That's
we're
great,
happy with it,
yeah.
but we have to make some adjustments to meet
Mhm.
that. So
Mhm.
we're doing it the best way, we're getting in with all the other larger companies, our typical no-show fees,
Oh, yeah,
restrictions
yeah.
being forwarded. It's a change, but it's a
Mhm.
positive
Good
change,
change,
right?
yeah.
It's a necessary change.
Okay.
I would like to ask this question. Is there, when you put a case together and you're getting ready to send off the charges and everything like that, does a doctor review that before you send it?
Now, we have a medical billing coder that we use
Okay.
for, it looks at the charges and the amount of time and the notes themselves of what the provider put in there.
The reason I bring it up is my son is a doctor up in Pennsylvania, and he says he spends probably 50% of his time going back and reviewing the write-ups, charge code, everything like that in the procedure, just to make sure the hospital gets their money the first time around. Now, I know that's not a good use of a doctor's time, but obviously that's what you're addressing is insurance companies trying to whittle it down.
And not pay for services.
It's the middleman. Let me put it that way. It's the middleman that's doing it.
If you're not coding right, you're not getting paid. That's the bottom line. So you have to code, you get paid, and we've been down that road before.
Well, it's also the write-up.
Yeah, the write-up. Yeah.
The write-up has to support the code.
Yeah. And what they use now, they got AI, most of these insurance companies. So they have an AI generated system. So if you write your stuff up, if you got one thing that is not cross-right, they reject it.
Yeah, they take the first 4 diagnoses if you go into a physician's office. So if your provider thinks they're doing you a service by putting on 13 codes, they're going to take the top 4. So make sure your provider puts your most important diagnosis in. Right. But anyway, on another note, the flu and strep is going around quite a bit. Please use your hand sanitizers and masks. I would appreciate it. Any questions about it?
It's more business, though.
I got a question for David. When are we going to get the new phone system going?
We had a conversation this morning. We're ready to talk about that.
I'm going to put you on the spot now. It's time to do it.
No, we're waiting on Consolidated right now to give us a date to turn the ports for the phone system. So we're waiting on them. They didn't want it now. We've just been waiting for them.
Call them every day. Do what you need to do. We need to get that going. That's something we've been
We've
doing.
been on it. They were ready to go, but we kind of pushed it back because we wanted more training.
I understand.
And
I
we had
understand.
to change some forms out in the inpatient area as well.
Okay.
We've got the mercy of them.
Susie decided she don't need a new phone system.
No, we all do.
I have a question.
Susie?
I have a question. Susie, did you say the flu and strep? Strep was the other one. All right, thank you. And I have a
Don't
statement.
shirk something off. If you're running fevers, get them checked out.
Yeah. I have a statement as well. I'm a frequent flyer over there with you all, between myself and Mrs. Retha McCaskill. And I have nothing but good things to say about your staff. You as well, but I come in contact with your staff more than I do you. And I do know about that walk-in. And every time I've had to bring her in, you all have made a way for her to be seen. And I think that's so important with her being 97 years
Yes.
old. Thank you so very much.
You're welcome. Thank you.
Since we're talking about the clinic stuff, just one thing, we don't have any measles cases. I know there's a measles epidemic throughout the United States. We don't have any in Franklin County. I don't think the state of Florida have any that we know of. Now, maybe some, that haven't been reported yet, but we don't have any yet here in Franklin County. I don't think we had any come through the ED. Haven't had any come through the clinics as well. So I'm just putting that out there because that's a
Let me ask you a foolish question. When I went to school, you had to have a measles shot before you went to school. No, we didn't. They didn't have it then. Everybody got the measles then, Or people Kids going to school not required to get a shots and everything.
I don't know.
I just curious.
Yeah, I don't know what the system is here in Florida. I would
Well, you can get a,
assume
re-
so.
well, you
I
can
thought
get
they were
certain-
going.
well,
I
you can
thought-
get certain, you can get certain exemptions. You know, you get a religious.
Okay,
exemption.
I understand. Okay, I just questioned. Didn't know.
I
I'm
mean, they're required, but
not,
you can get certain exemptions.
I'm not yay or nay. I just know everybody got the measles, the mumps, and chicken pox. That's three things she got. Yeah.
Polio shot.
Or your,
Got the
your mom
polio,
put you in the
polio
room
too.
with everybody so you caught it. Yes.
Not hot. You got a little cube of sugar with a little dot in it. You took it. I'd never seen that before in my life. Remember, I want to do it again. You know, you lined up. Did y'all get that? The little cube. Polio was a terrible thing. You know, back then. Okay. Thank you, Susie. Good report. Okay, what we got here now? The ambulance, EMS, Mr. Osteen.
Morning. All right, first off, I just want to go ahead and say, this month so far, we're at 72% transport rates. We've had 83 billable runs, 32 non-billables. We finished last month off at 72% as well. I don't have the exact numbers, but I do know it's 72% also. So that's up from the end of last year. And I guess we'll just go ahead and talk about the elephant in the room here, the overtime.
Yeah.
All right, so I am currently watching overtime. I'm trying to minimize the best I can. And how am I doing this? We've had actually 3 open spots the last couple months. I've had one person out with an injury. She's been out for the last 2 months. Well, she came back today. So that'll help there. That'll help fill that spot. I have one full-time paramedic that I hired last month. He's on his last day of orientation today. So starting next week, he'll fill one of those spots. So that's another spot, another empty spot that's full. I have one EMT part-time. She's still in orientation. She's brand new, so it might take a little time to get her off orientation. Once she is, then I can plug her in one day a week to be able to kind of minimize the overtime as well. And I just recently hired another part-time paramedic last week. So I'm waiting on her to get all her HR stuff in. Wait to come in and get her urinalysis and get all that stuff done so we can get her on board. She has a lot of experience. She's actually the EMS director of Liberty County. So she just wants to come here just to work one or two days a month to get a lot of extra money. And that'll help, again, minimize the overtime. So last pay period, total overtime hours were 181 hours. That's the last paycheck.
And you said, talking about twice a month?
That we get paid twice a month. So last pay period was ended February 23rd. That was 181 hours for that one. Now, unfortunately, this one that ended. I'm sorry. Last one I'm talking about, the 181 hours was ended on February 9th. The one that ended February 23rd, we were at 303 hours. We're trying to get there. We just got to cover trucks. It's a matter of covering trucks or downing trucks. Don't really want to down a truck. We have too much surface area to run.
No, we're not down in a truck.
I have had one resignation. Got his resignation a couple days ago. One of my full-time captains. I'm not going to fill that spot right now until we can figure out what's going on with the county employees or whatever they're going to wind up doing. So I'm just going to leave that alone for now. We're not going to fill that. I have a step-up captain on that shift that can step up and do that work for temporary.
Did you have an exit interview with this captain?
He's not gone yet. He will. His last day is March the 9th.
Is he working in another county?
He's going back. He's going back to Wapella County.
I think advertisement they put out there is affecting everybody, isn't it?
Yeah. But this was his. The stuff going on here. That was his final push. That was his final determination of what he wanted to do. He was thinking about doing it because thinking closer to his fiance and his newborn baby, but this was just kind of that. Okay, let me just go ahead and do this. That was the final push. I just got him to go back to work college.
Let me just mention this also. The EMS runs in December was 117. Ending January was 145. So you see, we're much more busier in January. James is doing a great job in hiring and recruiting people in this, but we still got to look at some strategies for EMS. Try to get the overtime right, as well as to get the the salaries that we have. We want to be competitive with Gulf County. We're already competitive with Liberty. Now, we'll call up. They have a different kind of system here. We have to look at those particular salaries and see if we need some wage adjustments as well. But he's trying to make sure he work up some other strategies for EMS, to try to make sure we're in a manageable situation. And some of the things happen here too. We have different events here. So when you have different events, you want to make sure you kind of full staff. What I mean by the events, we had Mardi Gras, the golf Mardi Gras earlier. We had oyster cook-off. Got chili cook-off coming up. So we may need to look at also, look at our high runs in the year. How we running in the year, and if we're low, do we need to make some adjustments? With our captains on the truck.
I think if given your report, if you were to give me those numbers again, they're not telling me anything. What I want to know is, what do they do your baseline? When you project it up front, like the budget for the year and how it broke down monthly, how does that actual compare to the budget? Because then I know if you start to go skewing one way or the other.
Yeah, and that's what David, is if you're going to look at the financials, that should be there.
Well, hold on. I don't see it in the financials here. I don't see the breakdown. Is it?
Yeah. So we look at, more so in the financials. We'll look at that.
Weems Hospital.
Instead of
More so in the
Hospital
report,
summarized.
because it's a verbal report that's going out to
Yeah.
the public. How do you measure up? Here's what you got, here's your actual, but how do you measure up?
Well, now, one thing with this too, there's overtime hours built in. Of those 181 hours of overtime, roughly, what's built in there?
That's additional.
That's additional, that's additional to what's built in. So there's built in, okay, yeah, I've looked at that staff, and there's no other, if you try to change that, people will leave us. They're not coming. How many local folks we have now? We have 4. Okay. I want to address the board on something. The county board was not very happy with me the other day in a meeting, and I don't blame them. Okay. And it seems like I didn't advise the board on something. Well, on this overtime and a situation like that, and I don't remember if I did or not. We always know it's a situation right there. So the board members, if I didn't advise you, I didn't advise you. Okay, I don't remember specifically if we mentioned that. I know overtime has always been a contention due to vacancies, and I just assume we're doing all we can with it. So that's it right there. So they were more than a little bit upset with me, but that's okay. They're not okay. I can handle it. But we got to keep looking at that all we can. I know you are. I don't know how to hire local people if they don't want to come to work here. I mean, advertise, and keep it going right there. So.
We're going to go ahead and get some flyers out to, try to get some flyers out to Cipolla College, with the paramedic and EMT schools out there. Try to get some out there. That's where most of our people go when we put them through. They go to Cipolla. So we'll see if we can get some return out of that. The EMT, we actually got her out of Gulf County, or I out of Gulf Coast Community College, so she came to us from there.
Well, something looks like it'd be just for the future. How long is that school?
EMT?
Yeah.
It was roughly 6 to 8 months.
6 to 8 months.
And your paramedic is another, it's 3 semesters, so about a year.
Would it be worthwhile talking to the school and see if they would get a starter program with the kids going to school, if they had a interest in that? Is anybody doing that?
You talking about the high school?
Yeah.
Yeah, I know Louis had started a conversation with them when he was here. Like almost like a feeder program. We can have another conversation with the superintendent.
I think it'd be worthwhile, you know.
I do believe the high school has a medical.
Yeah, they have a medical
academy.
They have a medical academy.
For what?
They got CNAs. I know CNAs. I don't know if youngsters in there or not. Just CNAs, and we can see if we can tie EMT or paramedic to that as well. I know we had a conversation with the last person that covered that class. The guy that I forgot his name in the district office.
I think it's worth checking, you know.
We can tie EMT into it maybe. Yeah. Not very much. You got to be an EMT before you can be a paramedic.
Yeah, okay.
Well, I think EMT then work towards paramedic.
Well, do they do a job fair or anything like that for seniors?
Yeah, they do. Yeah,
we should be on that,
Yeah, we
you
are
know.
there for that. Yeah, we do that every year. You know, not only EMS, we have the clinics out there. We have Courtney and her team is out there. EMS is out there. Matter of fact, EMS is out there with the truck.
We have a big presence out there.
Big presence.
Can you explain to me real quickly, when you say, and I've heard it a couple places, built-in overtime, exactly what is it?
It's actually, it's scheduled, it's part of the actual scheduled overtime, the time they work. So if they are scheduled for, two-week period, which is what our pay periods are. So they're scheduled for 120 hours. Inside that 120 hours is built-in overtime. So 80 hours of that, 80 hours of the 120 will be regular rate, which is their regular, whatever the regular rate is. And anything over that is their built-in overtime to equal that 120 hours.
Okay, so you're not running a 24/48 or a 48/96, right?
We're running 48.96, but if you're working at the 48.96s, 1 week of that, you work 48 hours. The next week, you work 72 hours. So those two combined is 120 hours.
Your overtime is on a two-week period, not a 1 week, correct? Okay, it's a 2 week
We
period.
break it down after 40 hours per week. Break it. So, you take 40 hours per week, and then so 80 hours for 2 weeks.
Okay.
So everything in the first week, anything they work over 40 hours. So if they work 2 shifts, which is 48 hours, 40 hours is regular time, 8 hours is overtime. And that's the built-in. So anything over that would be the additional overtime that work. That's the
I got you. Okay. So we're competing with. Is that that's a standard shift for EMTs, firefighters, and everything
Yes,
like that? I mean, that's
the standard now.
okay.
In this day and age, the 48.96s.
Right.
Back when I first started years ago, standard was 24/48, 24 on, 48 off. And then it's actually, as we progressed through, they found that 48.96s were actually more beneficial to the employee. Might not be beneficial to people paying the employee, but it's beneficial to the employee because of time off, recovery time, de-stressing, et cetera, et cetera.
And what's Wakulla got?
What colors were, they worked 48.96.
So if we try to change that, we're competing with Wakulla. That staff, they'd probably shoot right to Wakulla anyway. Or Gulf County, Liberty County, they're all about the same schedule.
Yeah, Gulf County, I believe I'm not 100%, but I believe they're 24/48 still.
Okay.
But they run a basic crew too. They're hurting just like we are for personnel.
Okay.
Everybody is.
Okay. All right.
James, wasn't one of the things we talked about is if you went to be a county employee, your OT started at 53 hours, not 40, right?
That's if you're fire rescue.
Only fire rescue.
That's if if you're affiliated, if you are certified fire rescue, and you have firefighter standards, then yes. But if you don't have firefighter standards, then
It's still 40.
There's a, what you call under the Fair Labor Standards Act, a 7K employee. But to qualify for a 7K employee, you have to be under the county for 1 and 2. You have to be trained in firefighter 1 and firefighter 2. But the positive side to that is, if in fact you are trained, then you run, if I'm not mistaken, David, you correct me, I think it's what, 216 or 210? 212 before overtime kicks in. And there's a way of doing it, but you got to bring them in under the county. You got to get them trained, and that might be something we want to look at later on. Is if they go to a countywide fire coordinator, where with the if you brought them in and put them under that position or under part-time supervision of that to make sure that they got trained in firefighting, you may in long term be able to reduce the cost of overtime to the county.
So
Is that correct?
Essentially, yes, yes. Essentially, anybody who came up would have to be firefighter, EMT, or firefighter paramedic, and then of course, that would put them on 53 hours. Then you have to incur the cost of everything else also. The cost of the equipment, getting the turnout gear, getting just this and that, the apparatus. You're going to have updated apparatus. It's kind of, it really needs to be like that. You need to be a fire rescue because we're volunteers, and I love volunteers. They're great, but if they don't feel like going, they don't have to go.
Yeah.
And it's just, I'm glad our volunteers do have to go to stuff, because if not, we'd be in a world of hurt. But I do think
We won't be able to get the insurance, or it cost so much we couldn't afford it more, yeah.
I have another question. Has anybody ever looked at, or are you aware of, David, this is to you also, these EMTs that are coming out of college, their training courses, is there any type of program set up that the county would come back and reimburse those people for their education and working over, say, a year or so period? So that it's an incentive to not only get your prior education costs back, but at the same time while you're working. Follow me?
I don't know about them coming out, but I do know we have to go in. If we hire them, essentially it's paramedics. I don't know how the EMT thing works, because they typically have to be employee with us, and then we can send them to paramedic school under a grant, essentially in-house grant type deal, or scholarship.
Right, it's a scholarship program after the fact.
Yeah, you're talking about coming from college. I know that that's something that we can look at with the colleges, Gulf Coast, TCC, and Chipola. Just to put that out there as a recruiting type of deal. That if you come work for us as an EMT and want to go into paramedic school, we'll scholarship you. And I know that initially, Lou and I, Louis met with the instructors at, Tallahassee, as well as Panama City campus. Could have been Chipola too, to try to work something out there. But we hadn't did that yet. But that's something that we can look into, set something up, as a recruiting flyer going out.
Right.
Let me tell you what, it'd be real simple to give them a hiring bonus. A bonus,
Yes.
come to work here. That cuts through all the red tape right there.
And I think that's what Mr. John was asking, is if somebody coming in out of brand new EMT comes over, says, hey, I want to work for you, can we reimburse them for their schooling to have them work here for X amount of years? But I think that would be the bonus.
A
It's
bonus.
bonus, but you have to tie them into some type of contractual relationship.
Yes,
To
yes.
last for a year or 2 years.
Our paramedics, we put through, we do a 2-year contract.
Yeah. And so what Ms. Beer was talking about, what we can do, we can contact the instructors at the different colleges that offer, the certifications, and then put out a flyer there at those areas that, hey, if people going through EMT schools, if you come work with us, we'll scholarship you for your paramedics.
That'd be good too, but when they walk in the door and they want to come to work, say, we're gonna give you a $1,000 bonus to work for us for a year. I know, that's the problem, and you'd have to, I know, I'm not, hey, look at her, you want, I know that.
I want that too.
Yeah, because really,
That's
one of
not,
the,
right,
yeah.
that's not what I, that's not what
Yeah, but
You were quiet for a long time.
Yeah, but,
That got her going.
Yeah, but if you look, be all honest with you, if you look at the hospital, our staff, it's the lab department, really. The lab department is one that we want to offer some kind of bonus, because that's the hard field position, but what the Spirit and some of those talking about, we're talking about when they in college at EMT school, want to come in, we can begin to offer them scholarship, they come work for us. That's how you get them in the door.
Currently,
You got
they're the
options.
only ones with that opportunity as well.
Yeah, the ones that we have here.
For other people, in my opinion, as well. You guys, you guys, I mean, it has been offered to them for years.
Yeah.
When I remember, but
Yeah.
we don't have that opportunity in other departments.
Go back to sleep. Hey, just go back to sleep over there, okay?
But we'll look
People
at,
over here.
That kinda.
no, but we'll take a look at all of that. We'll take a look at all that, but, of course,
That's
EMS.
something that's gonna offset, and I'll put it this way, that advertisement I saw come out of Wakulla County for EMS.
Yeah.
Because that's impressive when you see that in the Wakulla news, this and that, nobody wants to leave when they see all that lined up. Right, Rob?
Yeah.
Well, the county right now is, I guess, studying the possibility of making the ambulance county employees for the, for the retirement. I believe they're undergoing a study. The question is, then the hospital's not. There you go. The nurses won't be. So I mean, I don't know. We'll wait and see on that. Ambulance. Let's make sure we stay on top of ordering ambulances.
Yes, sir. I'll put a proposal on next month.
We got to do it 2 years ahead. And if we ever fall behind on that, we've got problems.
Hopefully they'll, when they open their new factory, Frazier, when they open their second factory, they'll cut back on the amount of time it's gonna take to get it turned around.
Let me make a statement. Ms. Osteen, you really are on top of everything, it appears to me. Thank you so much. Doing an excellent job there. Yeah, anything else?
Yes, sir. Unless y'all have anything else.
Okay, quick break.
Thank you.
5-minute break. 5-minute break. Let's get started again. Craig Gibson, the plant operations update.
Good morning, everyone. All right, I got a few items here. I know the phone was a topic. Consolidate has kind of been our thorn in our backside. We're waiting on them. Like David said, Kevin keeps us informed on that, and just as soon as they get it, we'll be ready to go. We did get a tutorial put out by Casey Lumens with IT for everybody to look at on their computer to show them and walk them through how you set up that phone.
So is it, Greg, is it the training that's holding us up, the training?
Yes. Yeah, what it is, you just read it. Everybody's going to have to go in. You're going to have to set that up for you. You're going to have to put in your email and put in a passcode and everything and get that set up for you personally. And then it tells you how to go in and you speed dial, your recordings, everything is like that.
But Consolidated has to turn over before.
Yeah. Consolidated has to turn that knob on. That's all.
Well,
we're
I
waiting
imagine
on.
once we have the training done and you're all signed up, you can just tell them to turn it on, right?
No, we're telling them now to turn it on.
It takes so long?
Yeah, we're just waiting on that.
They have to turn off one system and turn on another system.
Okay.
Update at Weems East, Carabel. We installed the new lobby flooring this last weekend. After the meeting today, Susie and I are going to sit down and we're going to pick out some samples for the front restrooms over there and get that in the process of getting new flooring in there. The issue with the water flow over there, the plumbers commented over there a couple of weeks ago. The backflow diverter is our problem. It's reducing our water flow about 18 to 20 psi because it's not operating right. So we've ordered the new part. It should be here next week, and we'll resolve that issue. Right now, we're running anywhere from 60 to 80 psi over there, and it depends on, of course, whoever's down the street using the water. So it's going to go down a little bit, but we're going to still be able to, with this done, repaired, we'll be able to flush the toilets like we should.
Craig, you got an inspection scheduled for those backflow preventers everywhere, or are you? Okay, all right. Yeah.
CT project, we're moving forward with that on both areas. I'm sorry, here at the hospital. I've been in contact with the contractors and the architects. I sent them the last little bit of information they needed from me, which is paint colors, door style, countertops for the sink area, things like that. So they're done. They're ready to go. As soon as they get an appointment with ACA, they'll let us know, and we're ready to start that process. I completed the functional program form a couple weeks ago. Got that to them. What that is just basically us telling them we know what's going on, and that's an optimal problem. That's been done. Mr. Berry, this is for you. A couple of months ago, you asked me about surge protection.
Yes.
Okay, got an answer for you. I am actually meeting with Scott Nixon from Duke Energy on March the 5th. He said that they don't do anything for surge protection from Duke Energy. That's our thing to do. He's going to come here and he's going to walk through. I'll show him all the equipment that I'm talking about. He'll give us some recommendations and walk us through that project. He just completed the project at the Perry Hospital the same day. Yes, sir. March the 11th, I'll be meeting with the FEMA historian regarding our window replacement project. So hopefully we'll get that taken care of and see if there's a process that we are really going to get new windows for the hospital and the clinic over here next door. And I'm hoping that's what they're coming to tell us. So I've got a meeting with them.
Yeah, that's been on the list for a minute, like the generator also. Once we do the windows, I'm sure ACA has to get involved. And the windows is a very detailed review from ACA. Last time, the screw was too long, they killed the part. So they're very detailed on that. So we're very excited that we got, we're at the county, will give us money to do all our windows, and we'll be hurricane, ready for that.
Yeah,
With the generators, we'll be hurricane.
What they've done right now with the generators, they've trenched out, laid the conduit underground, and they've formed the form for the concrete pads in both facilities. So we're just waiting on them to come back for that and start that process.
New generators?
Yes, sir. Here over in Carabel. But it's 16 to 18 weeks, they're still on that timeline. to get
That-
to get that done.
Does that include the automatic transfer switch also?
Yes, sir. Yeah, they've already got it stuffed up out here. They haven't put it inside the electrical room yet. but-
What kind of generator are we getting? What are we getting? Caterpillar?
I don't know if it's that. I think a cat.
Cat, yeah.
Don't hold me to that because I'm not sure. I don't know if he ever really told me what we're getting. It's a 400 kilowatt.
Cat gives the best service of anybody I've seen.
This is that equipment that the governor had made a recommendation
Right.
for our county a couple years ago, 4 years ago. 4 years ago. Okay, wow.
Yeah.
We finally able to move on that. That's going to help us out here.
Yeah, that's great. That's great. Something I really wanted there. That's good.
You have another question?
Yes, I do, but I'll talk to you.
Okay, all right. We have finished installation of the new cameras. Here at the hospital, we had 16. We've now got 7 more, so we have a total of 23 here on campus. Clinic in Carabel had 8. They now have 11. The Weems West next door here only had 4. They now have 11. So we've matched that. That's pretty much it.
We have a lot of things going on, really,
Yeah,
a whole lot of things.
So you have an app on your phone for these cameras? So
Yes,
that
sir.
can tell you
Yes,
if
sir.
something goes out, you go back and look at the recorded events?
Yes, sir, Mr. Walker and I both did. And once we get, now that we've got them all in, there is a program that I'm gonna get with IT about. And since the clinics are closed after a certain amount of time, there's an app that that will be put on our phone that will alert us if somebody's in those clinics after hours. I'll get with Susie and determine what hours that she says that, staff will be out there, and especially like on weekends.
So if they have
Craig.
come in an emergency,
Everybody calls me. I have to where my staff calls me and let me know they're going in.
Yeah.
Because-
Craig, you got some little handwritten notes on everything you covered there?
I've got a page. Yeah. I'll send it.
Give me a copy, okay? Just a little simple, I mean,
No, I've got it printed out what we do.
okay. All the board members might want it.
But we're camera secured here, I think that's good, that we just got eyes around our facility. A lot of
Yeah,
things.
got to.
Yeah, you got it on guard. Well,
Well,
we
people
get so
don't
many
know.
people putting stuff in, and just to help maybe capture that, because our guys don't want to scoop that stuff up sometimes. I mean, we've had electrical boxes put in out there.
Have what?
Electrical boxes, old, rusted, huge ones. That it took me inventory to pick it up and put it in.
Yeah.
Yeah, no, we can't.
Can you tell me how long? Sorry. The projects that you just reported on, how long have we been working on this?
Rough, on the generator, roughly about 4 years.
Yeah.
Yeah.
That was spring. And, sometimes grants take a long time, plus being tied up with government. They decide when they want to let you have that money.
That's right. That's right.
So, here we are.
Yeah.
Thank goodness we're.
We're here. That's right.
I was shocked when they showed up, because I hadn't heard anything in a year. When I first got back here in 2011, 2021, I met, a couple of times here and over at Carabel, on 2 or 3 different occasions with several different contractors. And I thought, okay, great, we're fixing to get it. And then it just kind of dropped off the scales. Nothing was there. The CT project, that's going to be more with the architect and the contractors. They'll meet with Aqua. They generally run, when you put in an application, 3 weeks, I believe is what we're told, to schedule and get an appointment there. Then we'll start that process, and if they have any questions, then we'll stop, come back. It's going to be a talking kind of process for the first part of it. And I believe they told us that if everything goes well, they'll start the project in June and finish around July 1st. And we should be operational after the 4th or somewhere around there.
That's wonderful. I like that eye contact when you're talking. Thank you.
Yes, ma'am. Thank you.
And the CD, of course, the CT project, we're very proud of that because I was looking at a lady the other day, Brian Steph, radiologist was walking out. It was very, very cold, and, of course, I told her that, maybe 6 months, come back, you'll be in my office here. Then it's raining, we're walking people out here, so, I just can't wait, although I'll be on another corner in the building somewhere, but I just can't wait until we get this thing taken care of.
Yeah, my blood pressure went up by 20 points after I took the ride over there. To be honest with you. I did. Yeah. I had the person that was doing that, she knew how to she knew every little bump and everything like that. Good. I know. Time to do it.
All right. No other questions?
That's it. Thank you, Craig.
Thank you.
Let's see, the next item is a line update. CFO report, yeah. CFO, excuse me, I'm sorry. David Boland.
We can ask him.
Everybody should have in their packet the financial statements for January 2025. And, I want to first, mention, we had, I feel like, very productive meetings with the Board of County Commissioners, and I appreciate, each one of them taking the opportunity to meet, and I got a chance to get in front of each one. I know Otis is still working to schedule some time with him. I know we've had some scheduling conflicts to be able to talk with him, but I really wanted to get in front of each of the county commissioners and just really discuss, what we're doing here, be more transparent with the information that's being provided. This is something, I'm going to encourage that we obviously do going forward. I would ask that, each of the hospital board members as well, and the county commissioner and the appointed board member, let's meet one-on-one and let's talk about the expectations for Weems, the expectations that Alliance is helping with, and just make sure everybody's on the same page. And again, work on our communication. And I think that was, as I recognized, with them, I think that was an area that we can improve, we will improve. So, but with that, I do want to walk through the financial statements because some of the things that we were able to break out, and hopefully the intention is to bring more clarity around this. We did break out the EMS. We are going to report that separately going forward. As James mentioned, I know there was a lot of discussion around that, a lot of maybe as I said before, miscommunicated information, but we want to bring that transparency and be able to show that information and discuss that as much as needed. So you will see that broken out in the financial statements and on a go-forward basis. And again, we're going to ask for any suggestions to report into this information, however is needed to make sure everybody fully understands or has a chance to ask the pertinent questions. When you look at the hospital as far as I said, January 2025, and how the overall consolidated, when I say that, it does include EMS. So when you look at the overall consolidated net income for January 2025, the hospital did finish at approximately $15,000. Again, $15,000 positive standpoint, which did exceed budget by approximately $11,000. So we were up over our budgeted performance for January of 2025. For the 4 months, so fiscal year to date ending, the consolidated net income finished at a negative 451. So we've got a hole there that we're digging out of. But again, the performance in January was positive. And I want to say that because what we have seen, happen in January with the related snow impact and storm impact that a lot of ice impact that a lot of North Florida facilities experience, we have seen across other Alliant hospitals that we work with, that disruption in revenue, disruption in services. Here at Weems, I know we were down about 2.5, nearly 3 days of interrupted services. So, finishing the month in a positive, although we were down, 2.5 to 3 days in services is encouraging to hear. Some key drivers for the month of January. Yes, sir.
I'm looking at it here, and tell me if I'm wrong. The variance of year-to-date is 1.3, right?
Just real quick.
You're talking about output?
I'm talking about revenues.
Or yeah, the revenue aspect. What I was referencing, Mr. Zestri, is when you look at the net income.
Okay, you look down at net income.
Net income.
I mean, the expenses stayed pretty stable. It's not crazy if you look at the expenses, 129,000.
Sure.
But if you look at the revenues, that's 1.3. So it's not expenses that are creating the issue; it's the lack of revenue that's creating the issue. And I know we're down a couple of days, but a couple of days, 5 days equals 1.3 million. I can see that.
Well, we'll walk through it. I got some comments, and one of the other things that I'll add too, as far as putting transparency around the numbers, you will see in your board packet a lot more
Detail.
You'll see a lot more variance explanations, which I think is going to be a plus going forward. It helps bring that transparency in the numbers. Let's go ahead and jump into what you're referencing there. Gross, for January 2025, and again, some key drivers that impacted that, the gross patient revenue, this is what Mr. Zester is referencing, did finish just under 1.3 million for the month's performance, which was about 236,000 or 15% down versus the budget. And really the drivers inside of that, when you look at the specific areas inside, chargeable gross patient service-related revenue, inpatient revenue was actually up during the month of January. It was up $17,000 with total patient days up 4 days, or roughly 9%. So
It's the outpatient, I think, that's
absolutely
really driving this, right?
Yeah.
Outpatient revenue was down $210,000. Now, remember again, recorded within outpatient activity is ER activity. The ER revenues were down $71,000. ER visits were down 66, or roughly 14% in our ER activity. That lesser ER activity did also contribute to declines in pharmacy-related revenues, lab-related revenues, as well as when you look at CTs being down too. When you got ER drop,
so we make the big assumption that the cold weather kept everybody inside their houses.
Well, it did shut down services for 2 to 3 days, but
it was cold January. It was a cold January,
Yeah,
sure.
Then when you look at radiology, of course, the ED outpatient drives that, but the CT machine was down.
Mhm.
Also,
Okay.
It's just not broken down.
Right.
the scans being down again, that categorized, and you'll see, as I said, we put some comments around that, but again, just to put dollars. Yeah, just put dollars around that. I mean, lab, when you look at 210,000 down versus revenue, lab was down 25,000 of that. Pharmacy was about 72 of that. Radiology was 47 of that, as David mentioned. I mean, CTs has been a big driver inside the radiology impact. Additionally, I do want to mention though, the clinics. I know Susie mentioned, when you look year-over-year, clinics need to be strong from a budgetary standpoint. It was down approximately $2,200. I mean, not a significant decline, but they were down versus their budgeted impact and so forth. EMS again too was down about 41,000. Ambulance billable runs were down versus that actual run rate what we had been historically running within EMS. But as James mentioned earlier, February has seen a turn in another direction. Just walking down the income statement, looking at net patient revenue again, as I say every month is what we anticipate collecting from the services that's being provided here. Net patient revenue did finish down approximately 54,000 or 6% versus budget. Again, this was primarily as a result of those decreased patient volumes. As would be anticipated with some of those declines in volumes that we have, cash has been slower, and cash has been slower coming in that aspect. Cash going out, and I'll talk about this in a minute from a balance sheet perspective. Some cash, there was a significant cash drop month over month, and you look at the monies that was actually paid for the trucks back to the county, about $500,000 or so that was paid over to the county for the trucks that was reported on their books. Hospital got the grant in terms of sending money over to the county. And then I'll comment here so that we can prep for the next month as well. There was an old liability on the books related to the TMH relationship from years back. Dates, I think it was around 2016, 2017. Hospital was carrying on the books. It is in your liability section. The liability is being relieved with the county suggesting a couple weeks ago or a week or so ago to go ahead and issue that payment to TMH. So that transaction of money has taken place this month.
We cut that check already?
That check has been cut. That check has been cut. That check is being delivered.
David,
That'll show this month.
It'll show this month red right now. It won't show in the financials today.
before you move on though, I don't understand on a year to date on outpatient revenue. It shows us being down $1,034, $304. That's does that need to be looked at closely, or I mean,
Well,
look at the second line there, outpatient revenue. Is there a need for concern, or I mean?
I think when you look at the drivers, to the chairman's point.
This is a year. This is a year to date now, not month.
Right, and drivers behind a lot of that outpatient decline that we've seen so far for this 4 months, right? Of this
Right.
fiscal year
4
date.
months. Right.
4 months of activity. So it's 4 months into that, and I think each month that we have reported, our ER activity has been down. Our ER activity has been down month over month over month here, and that is one of your main drivers behind these decreases that we're seeing from an outpatient standpoint. And 210,000 of it was actually related to this. 71 of that was in the ER. I mentioned the lab, mentioned the radiology, mentioned the pharmacy, those activities. But to your question, though, the main driver that's pushing a lot of our outpatient revenue down is related to ER declines.
Is what?
ER, emergency room declines. Lesser emergency room visits.
Can't do much about that. I don't know.
Let me ask
That's one
you
thing you can't.
a validity question. Okay? You know where I'm coming from, I think, already before I asked it, but somebody's got to be a little more conservative on the budget process, because that's what you're tracking against. Right? Somebody put a budget, a built budget out there, and when we're over and under, it's against what that budget was doing. Right? So if the budget itself was a little over optimistic, okay, then we're going to show deficits constantly. So, looking at your presentation, which I love, okay, looking at your presentation tells me right off the bat the budgeting process has to be tightened.
Well, we're also looking at against last year.
Yeah.
So you're looking at the variance against last year. When we say that we're down $1 million and change on outpatient revenue, that's last year versus current. So that's nothing to do with budget.
Well, you have, from a year-to-date standpoint, you're down 1.1 million versus budget and 1.3 million versus year-over-year. So, but
During the
we
budget,
look at both.
Yeah, during the budget process, we added, for certain items, we kind of added, we thought we conservative, like 6% to the margin go up. But when we did the budget, different categories, we had like 6% here, 4% here. We had David to get that for you. But different categories, we had. Only area that we really didn't add up on the budget is EMS. We kind of kept that flat, but I think maybe I'm going to have that.
No, absolutely. And I think if you look at, again, what drives revenue, again, is patient services. When you look at that, there's an operating statistics sheet that's in your packet as well, and you can see clearly the drivers behind that. As was mentioned to the chairman, when you look at emergency room visits, that's one of your main drivers. It's down 12%. It's down 209 visits from where we were this time last year. So that's one of the main main activities. Susie brought up a good point earlier. The clinics are up, so it is performing. Did we get a little more aggressive in the budget and push it a little bit higher for the clinics? Yes. Are they outperforming last year? Yes. Budget may have been, was challenged, right? Push a little bit, a little further growth in the clinics. But I think driver is going to be related to the ER activity. Is what we're seeing as a drop in performance. No other questions. I'm going to move down and talk about expenses real quick, or just a few comments around expenses. Total operating expenses, when you look at for the month of January again, revenues were down, but operating expenses were down $7,000 as well, or 6% versus budget. I mention this every month. Our personnel-related costs, salaries, wages, benefits, go into supporting our employees. We were up a combined $8,000. Again, I'm speaking about this and talking more again on that consolidated basis. It's up $8,000, which is mostly attributable to the EMS exceeding the budget. And again, it's broken out for you separately, but I'm commenting on it from a consolidated overall standpoint. And EMS, as James has discussed, I think we clarified hopefully with the county commissioners at the meeting as well. It's an area that we're continuing to focus on. We're trying we're looking at different ways to help with that cost structure, and certainly retain and keep the employees, the workforce that we had. It's discouraging to hear that one did leave with some disruption, but again, as James mentioned, he's doing a really good job, trying really hard to get this back in a better, more manageable, I guess what we'd say, position from a financial standpoint. When you look at purchase contract services, those were down approximately $42,000 versus budget. Some savings that we have seen. There's no agency or contract needs for any type of nursing or labor at the moment. Also within services is, I've said this in other meetings as well, our patient cash collections, or the services that we pay to the billing company, the True Bridge that does our billing and coding for us, is tied to our collections. So if that number is down, then that service is down. It correlates with that. Other operating expenses were up about approximately $25,000, which includes some unexpected, and again, hopefully the descriptions and commentary we put in the package is helpful for everyone. But we mentioned that there were some unexpected repairs that did take place within the clinic. We did also see some increase in utility usage from a water leak, and then again, workers' comp related insurance as well. It's another area that's been for insurance in general, is another area that's been somewhat of a challenge for the organization. I do also, before I jump off the income statement, I think I wanted to make a comment about this. I really have it in my notes, but when Craig spoke, it did make me think about, when you look at some non-operating revenue type activity, and he mentioned there's a great question about how long some of those projects have they been underway, and that did impact our revenue this month as well, because we were able to record some related grant revenues related, and then we put some description, again, some explanations in the packet, but we were able to record some grant revenues that had been on the books for some time related to the completion of the projects, the security system. We mentioned the IT switch, ER rooms, and some exterior doors. So we were able to release some of that income, or some of that activity that was on the balance sheet into income.
Who has the closeout responsibility on contracts?
Ensuring that we're
When I say closed
out.
Yeah, debt is taken care of. They owe us money, we get it, we owe them.
Any grant that comes in, we're responsible for closing out the grant. We send reports in saying that, for example, we send a quarterly report, right now, maybe monthly, quarterly, or monthly. Say, okay, we spent X amount of dollars. Are we waiting on these other projects, to spend at a later date, but we send it on a monthly basis. And we send a invoice to them, and then they pay us. With the state capital outlay grant money now, one of them they gave us, the first one we have to spend 75% of the money, 100%, they give us 75% up front, and another 25% they give it to us later. The second round, they gave us all the money up front at one time, for the rural hospitals. But we have to put it to the side, cannot touch it until we, put in the project, and we send it report. Yeah, we send it report.
No, there's no other questions on the income statement. I want to jump over and make a couple of just balance sheet, cash flow comments. I talked about cash a few minutes ago. We did see, the overall cash position is still healthy to the organization. I don't want to mislead, but there was a drop in cash month over month. As I mentioned earlier, the 500,000 or so that went back over to the county for the trucks, their books, the grant money came in, released the money back over to them. There will be some impact in February related to that TMH liability being relieved as well. But again, when we look at overall healthy, it is in a better position than we were in a prior year. Hospital days cash on hand. I do want to always like to mention that to the board as well. We're at 71 days cash on hand. The hospital did experience a slight improvement with our net patient receivables. Although did finish January at 87 days in net AR, and our goal, we want to push that to improve there. I know it's an area that's challenged with the uninsured population and underinsured population of getting paid for those services. And I always want to bring clarity around that. There's 25 plus or so days in that number related to uninsured type population that's being cared for within the hospital. When we look at the hospital does continue that manageable process with our payables. There's no vendors at risk. You see the vendor payables actually, if you see inside some detail, is down versus where it was in the previous month. Now we will look to balance that as far as cash coming in slower, cash going out will be a little slower, kind of balance our outflow of our activity there. But when I look at some changes though, and again I think it's worthwhile to note some changes in those liabilities related to the movement, as I mentioned before, with trucks and moving that grant monies out, and then also with some changes with additional ACA assessments that we have reported as well. We have dish money is still reflected in the books as well. That has not been relieved out of those liabilities. So you do see some liabilities that give you that presentation that it is up year over year, but it does include some of those monies that were put onto the balance sheet, as I mentioned before, during last year's audit process. And with that, I do want to make a statement too that I know the audit process is wrapping up. From my understanding, with Car Riggs and Ingram, and I want to jump in front of their plans. I believe they are planning to present next month the audit report.
Who is that?
Car Riggs, Car Riggs and Ingram. So they should have the audit complete next month and be ready to present next month. So that is wrapping up.
Yeah, once the audit gets complete, Brian Hall, the auditor, he'll present to the county commission as well as to the hospital.
Hospital board first, right?
How did we do it last? We could have did it last time.
I think we'd like to see it first. The audit goes there. That was my recommendation.
Yeah. So it should be ready next month. I don't want to jump ahead of it, but just in discussions, and Jason, Connor, and Heather, and wrapping that up, and Sam with them. I think they're at that point. The other activity that's underway as well that goes kind of hand in hand. The cost report is being wrapped up as well. That should be signed here by actually tomorrow, the 28th. That should be done. And that's the annual reporting of Medicare's cost report, which is 5 months after your fiscal year end. The FERS report, which is the Florida Hospital Uniform Reporting System, It's a requirement of the state of Florida. That report is being issued as well and submitted. So a lot of different regulatory-related reporting that's taken place. And I know Heather behind me here has been...
Mr. Walker, do you want to address the TMH loan?
Yeah, he mentioned about it.
I mentioned that. Yeah.
You want to comment to that? Because, I mean, that's, since we're talking about the financial statements,
Yeah.
that's a note that's going to come off our financial
It is.
statements, which is going to be positive.
It is. If you look in the liability section, it's about $570,000 or so. I think it's on the books related to that. As the county voted to move forward with submitting payment to TMH, the check was cut. I know the check was released here from the hospital and is being delivered to TMH. So yeah, that is in.
I got a question.
Mr. Barry, that was a note that we had talked about. Remember?
It's in your liability. It's in your liabilities in your January
Yep.
statement. It'll show released in February though, when February's books are closed out.
And also, I just want to the first report, we don't really talk about that report. That's a major report that we have to submit, to ACA, every year. And we do it like on a quarterly basis. Then yearly, they just wrap all this stuff in. But that's a lot of work with that. But I want to just thank the staff, here as well as, Jason Barnaba, Heather, and Sam, and Susie, people that really work on these reports. We had a cost report that was due. We had an ACA 340B audit that was due. We had a financial audit, that was due as well. Then we had the Baker Tilly stuff, that they've been working on, with Baker Tilly. And so, we don't have a bunch of staff here, but they've really been working, getting this thing taken care of. And I just want to just echo, they've done a great job, really, because there's a lot of, when they make these demands, we only have a small amount of staff. We have to, 2 or 3, we got to put it out, So,
Right.
So I just wanted, Heather and Sam and Susie,
Heather and Sam.
yeah, but Heather and Sam really, and Jason, really touched this. I just want to just thank the staff for that. That's a lot of work.
I got a question. Just clear it up. When Baker Tilly first gave their first presentation to the board, the guy said, one thing I want to tell y'all right now is that you have, and I want to say 80 days of average on accounts receivable. Is that what he said? 80, 85? I don't know how they, I don't know how they got that. Well, we could have about 5 if we just took all the debt off. We could do that. But we keep, is there, I know you don't want to have a lot of receivables, but I believe we keep them there in case we can get the money. Maybe I'm wrong. Would you explain that, please?
I sure can. I mean,
Do you have any heartburn with our receivables?
You got, I wanted to.
We always wanted to get the money, I know that.
We wanted to improve, yes. We want to get to better goals. But to your point, and that's why I mention this every month, when you have a lot of uninsured, self-pay related, underinsured activity, that's hard to collect money.
Yep.
And yeah, you can if you wanted to write that money off, but we keep it on the books and try to pursue it and follow the policies that are in place to ensure that we've made all the collection efforts that we possibly can to collect that money. That's in that number. And I'll say this, for public reasons too. I know that and the audits getting complete. When groups came in like Baker or any other group that come in, consulting group that come in, they're going to look. They're going to try to identify things, and we welcome any ideas, any thoughts around how some of the numbers can be improved.
Well,
that's fair to say.
One thing we've talked about before is could be more, have your folks that collect it be more aggressive, but I don't think we want to do that. I think we're just right. I don't think we need to be calling people at 3 o'clock in the morning and stuff like that. We know people that can't pay. I don't know. I just wanted to see the thoughts on that, and also I think our hospital's so small. 1 or 2 accounts where people aren't paying us would drive that up a lot, more so than a big, if the numbers aren't there.
Well, that's, from a materiality standpoint, like you just said, that's why I grabbed the balance sheet. We got $1 million sitting in inpatient receivables. $1 million.
Right.
That's a lot of money.
I got you.
But again, that's, that, there's a lot of money, as I mentioned before, is tied into the uninsured. It's going to be very challenging to
Right.
capture. And again, the team, I feel like the team personally, I feel like they're doing a good job trying to get.
You have looked at that, though. You
Yes.
keep, okay, good. That's
Well,
fine.
and again, too, it is part of the audit process. So when the financial auditors, and again, I don't want to speak for the, Carl Riggs and Brian and his team, but I know they evaluate the methodology that is put in place to value, right, to net down those receivables
Right.
to a collectability percentage that is compared to your historical performance. So I know they really put a lot of time into this, and Brian will probably explain it better than I can. He'll explain his process.
Allowance for doubt.
Allowance for
doubt.
That's correct.
Okay.
A lot of
Okay.
energy.
But that's funny because it seems to be just a static number. It doesn't seem to be a percentage of your receivables. It's 1.4 no matter what, it seems like. Is that just a number we picked out of the air?
That's
or
a, that's
we do it on a
a
percentage? or
estimate,
what do we do?
yeah.
It's an estimate that is provided through the audit process. Like I said, they true that up.
So they use that for the whole
Yeah, but you got a
year.
contractual
Yeah.
adjustment that's fluid. right?
Historical
That's the
numbers.
moving- That's the moving allowance that moves every month related to what's anticipated to be collected on those receivables that's been charged out.
How long do we carry these accounts before we, what's the policy before we write them off?
Well, typical process, and Heather, I don't, correct me if I misspeak about this typical process. I mean, if there's no payment plan, well, you're going to attempt at least, over 120 days, or up to 120 days on a self-pay related account before you turn it into a collection. So you're going to make an effort, about 3 to 4 attempts to collect on that balance. And then if there's no collections on that balance, and or no payment plan has been set up for that particular patient, then that money typically will be moved over to the collection agency who will pursue it as well. They'll work their efforts and then ultimately return it back to the hospital after their period of time of working it. I don't know exact their period of time. I can follow up with you, but they'll work it and make their efforts, and then they'll send it back to the hospital and say, hey, they deemed it worthless as well. Then the hospital will adjust it off to that point. So there is a policy and process in place.
120 days is about what everybody uses, I think.
120 days is pretty standard and
Mhm.
recommended. Obviously, it's what Medicare requires as well. But you're carrying it on. Now, it's valued down. The only other comments I'll make, again, from, looking at those key projects, financial operating indicators, again, hopefully in the packet that's being provided, the graphs, the breakdown of the breakout of the EMS, the bullet points now that has commentary. Again, we want to put as much information as we can. I apologize if it's information overload, but we want to put as much information as we can so that everyone has enough information to react to and ask the appropriate questions. So please, if there's anything else you need or you think is needed, I'm going to suggest those meetings with the Board of County Commissioners as well. Again, for hopefully transparency and hopefully meet expectations and address that with everyone as well.
And also, just, I know there's some questions earlier about the budget, the budget assumptions, that we kind of derived our budget from. If anybody want a copy of this was presented back in September, August, to the board members, but this just tells you, like for acute admits, we kind of pushed those numbers up 3.7%. Outpatient visits, we increased that to 10% because we were seeing an increase there. Swing beds, we did a 6% increase on that. Radiology, due to the new mammo program, we did 5%. In the rural health clinics, we did 13% there for the budget, increase there. But I have this copy if y'all want this copy. I can give you a copy.
Can I ask a clarifying question? You don't adjust the budget anytime during the year, do you?
No, sir.
No.
Okay.
No. I know there was a question earlier about, about the budgeting, were we too not optimistic on the numbers.
Right,
per se.
as I understood at some point, I thought that there had been some adjustments midstream that upped that budgeted number.
No. Here's the budgeted numbers here, in the assumptions here. Now, we upped them before the budget year, because we thought we hit those numbers.
I have an off-the-wall question to ask you. What are you hearing at the corporate level or the people up above it as far as what this Dodge group is going to look at in the medical side? Are you hearing anything?
Not really hearing anything related to our hospitals or any changes in critical access hospital, any changes in rural emergency hospital. I mean, there's bills out there. I mean, there is some legislation out there right now that Senator Corey Simon is sponsoring at the state level from a Florida Rural Renaissance program that's looking to help provide more funding or more support for rural health care. But as far as from the federal level, we're not hearing or seeing anything that's coming down that we're aware of that's going to impact how we're paid for our services or our current status.
There may be a cut, as if you can look at the cuts. Now, I hear that Medicaid and Medicare was off the table. However, to make up that money that the budget is cutting from, if they cut Medicaid, then that may trickle down, to the states, local levels. But, not yet. I don't think those have been in the HSS, Health Human Services yet. They've been in the National Institute of Health, but for the overall HSS, that controls CMS, that portion, I don't think they have been in there yet, but I'm sure the product will be.
No, they haven't. But I understand they're going to take a big look at CPP. There was a lot of fraud going on. And there's a lot of clawback, I guess that's their term. A lot of clawback possibilities.
So our cash has improved from last year by $468,000.
Yeah, cash on hand sitting at 70.
We got vendor payability, payables of 2.4 million
Yeah, but
this month, and last year was 728,000. Big variance there. I mean, I just wonder.
Let me describe what's
Is that-
inside the vendor payables. Again, it's way there's other line items categorized under payables in this situation. Vendor payables here, what is truly owed to vendors is about $173,000. What's inside of, when you look at, when you look at what's inside and grouped under vendor payables in this report, which reflects $2.4 million, we have activity that's deferred revenues, which is categorized.
Okay,
as
so,
payable.
okay, I understand. I got you,
It'll be
I
reduced.
understand. That's misleading to somebody like me.
It'll be reduced when that's put in.
I know.
Yeah, so when dish comes in, then that comes on.
I got you, I understand. It's just, at first glance, you say, oh my God, okay.
Well, we did that because, remember, we were in a board meeting months ago, it was mentioned, I think, Ms. Spear mentioned this about, we didn't have the lip payback in there, so just to look at the cash properly, to have those kind of things in there, as well as your grant. So,
Well, and the other thing too is inside that number is that TMH or that TMH liability. So that will be coming out of that. That 50.4 should reduce
Well,
about
better
30
now. Okay. Okay.
Yeah, and since I'm up here, if there's no other questions on financials, I'll give a brief line update on this on the agenda. Just a few things, just three things really I really want to touch on and recognize. One is our governance board retreat that's coming up here in a couple of weeks. I want to thank the Zesters, Bill and his wife Colleen. We're going to sit on a panel to discuss financial sustainability, and we have two other groups outside of Weems that's going to sit on that panel. One is the hospital from Perry, Florida, who converted to critical access. They've been critical access well over a year. and the success story they've had on their financial turnaround. We got another facility in Alabama, South Alabama, that's gone through the critical access conversion, and they're really had some delays and disruptions with United Healthcare. It's been a major challenge for them, but again, their economic development officer is going to sits on the board there as well, is going to share their experiences and their decision. And we wanted to have possessors share from a foundation standpoint the decision to really restart, rejuvenate, reignite.
We are?
A few words, and Colleen will tell you. but yeah, but they're going to share their experience of what the foundation has been here thus far, and their continued involvement there. I think it'd be encouraging for others to hear as other hospitals look at this and try to get some things started. Something to be encouraging for you guys. The other thing I want to give an update on as well. We're looking at the payer contracts, and we have looked at the payer contracts, the main payer insurance-based contracts here, and again pulled together a grid that lists top agreements, looking at the terms of those agreements, looking at any opportunity to improve those agreements. That is a service that was completed and wrapped up over the past month. I've already talked about the cost report, and then lastly, I just want to, as I said at the opening, talk about the meetings with the Board of County Commissioners. I think that went, in my opinion, I think it went really well. I got a chance to meet one-on-one. Plan to do that as much as I can. Again, I want to encourage the board members to participate with the county commissioner that's appointed you as well, and those that are at large, please sit in on any of the meetings that you can, and let's just make sure that expectations are being met, and if we're missing something, please don't hesitate to let us know. Let's keep this thing moving in this better direction, and we've seen this improvement year over year happen, and hopefully settle the noise and frustrations that's been surfacing over the past.
I think that one-on-ones help, because just that, what you told me about the vendor payables, that's you don't understand that's the vendor payable till you see it, and every time we get a grant, our payables will go up till we finish up the grant. So, okay. Gotcha. Gotcha.
Any questions?
That's it then. Thank you. Appreciate it. Good.
You're doing a great job. Great job. We have a executive session with. We have an executive session for risk management.
Wait a minute. Whoa. Not now.
I'm just saying we're doing a great job. All right, just want to give you some quick updates. We've already dealt with item 1A on my report, but the Sunshine Health complaint. Earlier this week, we filed an ACA complaint against Sunshine Health. Sunshine Health is one of our insurance providers, that we've been having a hard time getting payment from recently. So with the provider that we've been working with, our provider network administrator, she got an email this morning, and she's reviewing all of our claims, and she's kicking it up to higher ups to make sure that we can get some type of payment with these claims. I think we may have maybe $150,000 out there with Sunshine Health that we're trying to get paid monthly on, $150 to $170. UCF College of Medicine, we have opportunity to partner with the Department of Health and UCF College of Medicine for a Community Heart Health Plus Learning Initiative. So this initiative is a quality improvement opportunity aimed at improving the prevention and management of really hypertension and heart disease here in our county. Our providers are reviewing this initiative, and if they're okay with it, then we'll partner with them. I think it starts in July. If not, we'll come back around the second cohort with University of Central Florida College of Medicine on that. And here's a heart health type of deal. We did this years ago with the Department of Health here in Franklin County on the state level. Also, Weems Paint Fest. We participate in in our Paint Fest project, we'll be sending out a press release. The Foundation for Art partnered with us as well as the Elder Care Center to paint ceiling tiles like this. These ceiling tiles here. So we'll be painting different ceiling tiles. We'll put throughout the facility as well as over in the East Clinic. Foundation of Art has a reach of 1 million volunteers. You know, they produce over 53,000 paintings. The gentleman that we partnered with had visited the hospital years ago and just was a recent visitor to our hospital. So that was a great project with Elder Care. Baker Tilly should be giving out a draft report. Should be tentatively scheduled to release on March 12th to the county commission.
Is that a final report?
No,
or is that
just a draft.
just a draft?
Yeah, a draft report. Excuse me, I probably said final, but a draft report tentatively scheduled to release on March 12th to the county commission. So if that, I'll watch Michael Baron's agenda. If it's on the agenda, I'll make sure I send it out to the board on that date as well. Florida Rural Renaissance legislation, David mentioned this earlier. Senator Corey Simon has filed a bill, Senate Bill 110. This bill legislation will address some areas of education, infrastructure, environmental, economic development, and health care aimed at improving quality of life in Florida rural counties. This is an important bill. I'll be at the Capitol March 11th. It's March 11th and 12th to do some more advocacy for this particular bill because, you know, this is one of the bills that we take advantage of, especially rural hospitals. That's how we got the CT machine. So if you see Senator Corey Simon, you know, thank him a lot for sponsoring this particular bill here. Our next meeting is March 27th, 2025. That's all I have. I don't have anything else.
Hey, David, I'm going to add one comment on that bill. And one of the other aspects of that bill is to help. You know, we're a critical access hospital, and we're, you know, obviously funded. What that means is we're cost-based settled or paid our costs, Medicare's share of their costs. And one of the actions or one of the items inside this bill is to have Medicaid as to do the same, right? So that Medicaid's share of the cost can be cost settled, or at least the hospital be recognized and paid for costs. I think that would be a huge additional win.
Will it?
That
Yeah, because if you look at, I think we're looking at about maybe $800,000 maybe gain that passed.
Is that in the legislature right now?
Yeah. Part of this bill was Senator Corey Simon.
Has it got through the committees?
No, not yet. He just filed. Yeah. But this is a Senate priority. So this is Senate President priority. And so the Senate President Bill Ben O'Brien, he's from a rural county. He's really pushing this, so this is his priority. So we know
who's pushing it?
The Senate President, Bill O'Brien.
Okay.
Yeah, so that's the Senate President. So he's pushing this.
Oh, good,
You know,
good. Senate President pushing
Yeah,
it.
so it's gonna be some good stuff.
Good. Wow,
All right.
real good.
That's all I have.
I got one thing to bring up. Are you through?
Yeah.
Anybody else got any questions? Last week, Bill Williams from Franklin County, our last meeting, Sheriff's Office, discussed the 7 acres behind the Sheriff's Department, and you remember this presentation, and they have a board of directors made up of one of the county commissioners and several good folks on that board. They asked the hospital to put, because healthcare is tied into housing, and to a member from the hospital board to represent the hospital board on that board. So does anybody interested in doing it? Bill, okay? Gonna be a lot of time involved. You got time, haven't you? Okay. Is anybody else interested?
I like that answer. I'm tired.
Okay. We need a vote. All in favor, Bill? I'm opposed to it.
We can mark that down as opposed, still pass.
Get a haircut before you go. I just want to bring that up, and Bill, I guess you'll update us on that as it comes, when you have the meeting and stuff like
Sure,
that.
absolutely.
Yeah, sure, we'll let him know, and he'll get your email and stuff like that. Okay? So, Foundation. Go ahead. I'm sorry.
All right, so I got some notes here from the boss. Foundation fiscal goal for 2025 is $25,000. hoping we can get to there. We put $6,200 in last year, earmarked for the hospital. We wanted to hold on to that money and
Yeah.
have another round this year to see if we could bolster that up to about $25,000. We hope we can do it. Primary events are fundraising events, and secondary events are community engagement events. So I'm going to give you a quick thing on primary events. The gala, which we had last year, is what we're thinking here is that we don't know that the community can support a big gala like that every year. So we're thinking this year we move more towards a alternative format, which would be more of a cocktail, heavy tapas, social event. So we're thinking maybe every other year we alternate, go from a big gala to kind of more of a cocktail thing with heavy appetizers and tapas or something like that. We're looking at venues here in Apalachicola to do that. We think we have one kind of nailed down. We'll find out this week if it is. So, you know, it would still be food and alcohol and music and some, you know, kind of silent auction items and that kind of thing. So that's not going to change. Also, primary events, we are going to have a table July 3rd at the waterfront celebration for 4th of July. We are partnering again with Maine Squeeze Lemonade, which we had last year. They were great. They sold out the lemonade that day. It was a hot day. It worked well. So they're coming back to help us. We'll have a drawing raffle for the tickets for the upcoming event. We're not calling it a gala. We're calling it, what is she calling it, a social. So that will be the kickoff to starting people's awareness of what we're going to do. We're keeping the similar date. It's the week after Seafood. And then a goodwill building situation that had presented itself, and we've been taking advantage over this last year of putting AEDs in different places around the county. James has been very helpful in going out with us. We've been getting pictures at all the places that we've put the AEDs. We put one out in Alligator Point. One went there. 2 went to Apalachicola Police Department. Prior to that, we had one in the post office, one down at the yacht club, and we just put one up we gave one to Carabel Police Department for their cars. They didn't have one in their cars. Lanark, we put one at their clubhouse. Yeah, so I mean, we've been putting them around town, anywhere in Franklin County that we can. We're out now, but we are going to put another grant in through the foundation to see if we can get some more. We also had a private donor that helped us fund what the grant didn't fund on that, which has been great. They wanted to remain anonymous, but I think they're interested in kind of making that an annual kind of thing, which would be
Great.
Wonderful. What else? That's the AEDs. Secondary event. We are going to be putting a table up at the Chef's Sampler. I don't know if anybody knows about that event, but it brings together food venues from all over at the Armory. That is March 9th. It's a great event, a lot of food. Get sample food from all over, different chefs and things. We're going to have a table there for the foundation, and we've put an invite out to several key people that we feel are going to be beneficial for the foundation's growth. So
Okay,
we have
great.
we have eight seats at the table. We were talking about doing something with the hospital regarding the seafood festival. Maybe you have a tent. Maybe we come into the tent and support some of that. Just be another whatever you want to call it, vendor at the event with you.
You could be there with some applications too. Yeah, I mean, really, that's a good opportunity to see a lot of people, you know.
Right, yeah, you know.
So that's-
With the big EMS trailer.
Yeah, I know. Bring them over.
I think the gala's rising tide rides all boats. I think is the theme for this year's event as well. So that's kind
What's
of
the thing? What is it?
rising tide lifts all boats.
Oh, that's good right there. That's great. That's great.
That's all I got.
Okay, thank you, Bill. That's a lot. The foundation has come a long way, and it's becoming a real focal point for the hospital, which it should be. And I think it helps us more than the financial part was great, but the exposure that we get. I mean, it's
Yeah,
really
the
positive.
positive PR, public
Yeah.
relations
Mhm.
out there, the connectivity between different departments and areas, I think has been positive, and we've gained a lot of access to people,
Okay.
which has really helped overall. I think networking is key.
Okay.
I have a question. The foundation, is there a criteria in order to be on the foundation?
Colleen's been trying to enlist new members for the board. The issue is, we have reached out to several people, and a lot of people are afraid of getting on a board. I think they're not sure
Yeah.
what that means or
Yeah,
how much
yeah.
time that's going to take out of their day, or
Right.
especially with working people. So she's had some difficulty. She is looking for somebody that has a financial background.
Mhm.
I mean, I think that would be great, a banker, or a CPA, something like that, because she does need a treasurer. She has been a one-man band.
Yeah, that's why I asked.
And that's been difficult enough during that whole gala situation.
Yeah.
She's had other people help support her on a per project, but she doesn't have anybody else on the full board that she can lay projects on and take a little bit of the strain off of her. So she is looking for people. Her criteria is going to be on a need-be basis, what that person can bring to the table as far as their background and experience. And I think she's taking applications. And if you have somebody in mind, certainly reach out to me or to her.
I just asked. She needs all of that, but she also needs people that will not make it harder.
Well, that comes with opening the doors for volunteers, because there are a lot of people that say they're going to do something and then they just don't follow
Yeah.
through on the thing, and that makes it more work for you when you have to go back, figure out what they didn't do, and step up and get it done.
Yeah.
So you need volunteers that are going to do what they say they're going to do, and they're going to get their hands dirty, and that's the hardest thing to find. A lot of people want their name on the
There you go.
billboard, but they
There you
they
go.
don't want to get their hands dirty,
Okay, anything else? Ms. Alford, you got anything else you'd like to add there? Woke her up again. All right, any board members got anything? Okay, this meeting is adjourned, and we're going to go to executive